Welcome, everybody. I'm Diljeet Singh. I'm a G1 oncologist on the executive committee for Physicians for a National Health Plan, and I'm giving a talk for Single Payer 101. We're going to just do a quick introduction to single payer healthcare and hopefully give you some guidance and different ways to approach different groups. For a lot of the people who invite us to speak with them, we share a philosophical background, and sometimes this is the cleanest, clearest, easiest way to connect with them. They reach out to us because they understand healthcare is a human right, and so we talk to them in that language, thinking about healthcare as a social service distributed according to need, not a commodity distributed according to ability to pay, not a business whose beneficiaries are company executives and investors, not the patients. This is a very valuable place to start a lot of times because most Americans do believe everyone should have access to good care without financial hardship. The basic idea that we are the only developed nation that does not provide comprehensive health care to all. And then a quick look at current numbers often is helpful when talking to people. 31 million uninsured in 2020. In the first half of 2020, 43% of US adults were thought to be inadequately insured. And sometimes talking about these definitions kind of early on helps people too. So what does inadequate insurance mean? As you guys know, it covers two different groups of people. One, those people who have insurance but have a coverage gap, and then those who are underinsured, or they don't realize when they buy their insurance, or sometimes they do, but most often they don't, that it's not going to cover the things they need. They didn't expect to get cancer, and their plan doesn't, cover cancer. They have a catastrophic plan that only, covers emergency visits, not preventive care. This past fall, I took care of somebody who was a part-time employee of a local county's teachers group. She was a substitute teacher, and she had health insurance through her husband. They both lost their jobs when COVID hit. And the month before she lost her job, she'd had a hysterectomy. And there had been the presumption when she had her hysterectomy that she just had simple, benign, non-malignant fibroids. As it turned out, she had an unusual form of fibroids that can have cancerous behaviors. That means it can come back. It can, go to other places. It can metastasize. The pathology was reviewed, and right kind of the week before she lost her insurance, and she knew she was losing her insurance, we kind of got all the pathology reports back, and she was referred to me but never able to see me because she lost her insurance. And then over the next few months started developing abdominal pain, pain when she went to the bathroom, when she urinated, when she had a bowel movement. But it wasn't until her husband got a job 6 months later that she was able to, because she had insurance again, come back and see me. And by then, it looked like indeed the tumor did have malignant behaviors, and it had indeed grown back and grown into her bladder and grown into her colon. And she ultimately now is she underwent a pretty radical surgery and now is in chemotherapy. And that's an example of someone who's insured, but then has a coverage gap. I'm sure you guys have lots of stories being in this world of people who are underinsured, or, specifically they come in. For me, the thing that happens most often is they don't realize that they don't have cancer care, or they don't have outpatient cancer care, which is how we give most chemotherapy now. The other example is preventive care. People, about 6 months ago, I saw somebody who had got diagnosed with a BRCA mutation, which is an inherited predisposition that has a substantial increase in the risk of ultimately getting breast cancer and ovarian cancer. But because her preventive surgery was considered a preventive healthcare, it wasn't covered by her insurance plan. And of course, with a 20% chance of getting a cancer that we have no screening test for, ovarian cancer, that is it's hard to truly consider that preventive. And the truth is, the idea that any health insurance wouldn't cover preventive care is one of the deep flaws of American medicine, that we would even think preventive care is a thing that we could skip. Regardless, the other important number, I think, is that this 38,000 die a year from lack of coverage, right? That's in the same range as people who die, who die of ovarian cancer and endometrial cancers. And when people say things like, well, we can't do anything about this problem, I think to myself, would we ever imagine saying like, well, that's not that many people dying of ovarian cancer. Why don't we just not worry about that? Finally, the last sometimes language I use around this philosophical perspective is just plain and simple, right? Markets are good for lots of things, not healthcare. We are very good at buying cars, especially these days where you can look up the costs of cars, all the cars that are available in your neighborhood. There's a bunch of organizations, Blue Book, other things. You know what you need. You know how many people need to be in your car. You know what your commuter needs are. This is completely different from anticipating your healthcare needs. And that's why we're not very good consumers of healthcare. The other part is when you have a health issue, whether you're in a car accident or you acutely develop bleeding or something that needs to be cared for, there isn't time to figure it out. You already bought your health insurance. It's not an opportunity to choose something that you need. Other perspective, and a lot of groups that reach out to me to talk with, to have me talk, share political beliefs, and the roots and ongoing history of the opposition in the United States to universal health care is racist, sexist, classist. The AMA initially opposed Truman's plan because they did not want to provide health care to non-whites. If you need background on this, the podcast 1619, episode 4 is devoted to this and speaks to it very clearly. Even now, there's much language avoiding coverage of undocumented immigrants. And then there's misogynistic approaches to women's care, right? A cystoscopy, looking in the bladder of a man, is reimbursed more than looking in the bladder of a woman. That doesn't make any sense, right? Same as there's lots of Medicaid programs that provide care to women while they are pregnant, but not after delivery. And I have done countless surgeries on women while they are pregnant, trying to take advantage of the fact that it's a time that they have health care, that ideally we would have waited until after delivery. Legislated limitations on contraception and access to family planning have a lot to do with two pieces. One, the fact that it is a for-profit business and that all of the things that drive reimbursement, all of the misogyny and sexism that drive those decisions are then inherently woven into the decisions we made. And then the fact that decisions about access to family planning are not put through the hands of healthcare providers. They are put through the hands of legislators that have either no knowledge about this or are making decisions for issues completely unrelated to what's best for the healthcare of their constituents, specifically women. The other way, and sometimes I lead with this when I talk to a chamber of commerce, when I'm invited to give sort of a pro-con discussion, I often start with the practical perspective. our current system is unsustainable because of the burden it places on our economy and our businesses. Premiums continue to go up, coverage continues to go down, and currently 2/3 of personal bankruptcies are medically related. The majority of people who go into personal bankruptcy for medical reasons had insurance at the time of the diagnosis that ultimately leads to their bankruptcy. Not to mention, we are the most expensive healthcare system in the world. Currently, we spend twice as much as other developed nations, but we don't get more care. Canadians see their doctors more often, spend more time in the hospital. We don't get better results. We are worse than most other developed countries on life expectancy, infant mortality, immunization rates, you name it, we do worse than the rest of the world. And of course, we still don't cover everyone. So how did we get here, right? We're outrageously expensive, we're inadequate. Why? Just to take a second to talk about the cost to business. These are old data, but I still find them so remarkable. The idea that $1,500 of every car made by GM was them covering healthcare costs for their employees, right? The idea that companies move out of the United States to neighboring developed country because then they don't have to cover the healthcare of their workers, that they can compete to get workers on, other issues, not providing healthcare. So how did we get here? The profit motive is ultimately taking money out of our healthcare system and putting it in the pockets of executives, of insurance companies, of pharmaceuticals, right? Huge administrative costs divert resources. And those companies, right, insurance companies compete not by having the best healthcare, not by doing it in the most effective and efficient method, but by avoiding unprofitable patients and limiting services, right? Those for-profit businesses have a responsibility to their shareholders to make profit, and that's what drives their decision-making. So the United States healthcare system is essentially set up based on a system that is trying to avoid sick people, separate from that profit motive. In order to deal with the for-profit system, there's an extremely costly process, bureaucracy, right? When I worked at an academic center in Chicago, we had 5 nurses who did chemotherapy, and we had 7 people who did our billing, because we needed to be sure Aetna covered the same things, or, was a different process than Blue Cross Blue Shield, was different than United Healthcare, et cetera, et cetera. And so we had to employ people to help us negotiate that and help our patients get the coverage that they had paid for. 31% of healthcare dollars are consumed by these 2 aspects, right? That's a potential savings of $350 billion a year, enough to provide coverage to everyone. The other argument that I hear all the time is, where are we going to get the money to pay for all this stuff? You liberals are blah, blah. The money is already there. The money is already in our system. And the very basic concept that if this is your budget, right? This is your personal budget for how you pay for your car, your food, your rent, and I just gave you 30% back. Most people can imagine what that means in terms of what we could cover. So the we can't afford it argument is false. And it's kind of insane now where we are and how this has evolved even in the last 20 years. Profits are gained not just on medical care, not just on drugs, but medical devices, lab fees, chemotherapy, physical therapy, occupational therapy, hospice, long-term care. And throughout the system, then there's pressure on providers to participate in the system where the goals are to maximize billing, with penalty, of course, of loss of income and job loss if you aren't able to participate in that maximizing of billing. The past year and a half has really been a case study in healthcare failure, right? The death toll in the US, outpacing those of other countries. And truly, it goes beyond politics and incompetence. We are not designed to care for everybody. Not everybody has a primary care doctor to go to get a COVID test, right? Many people, as we discussed, didn't have insurance at the outset, or their insurance was tied to the job that they then lost, right? Additionally, there's no trusted source for healthcare. So even now, some of the issues that we're having with people, whether they believe or not the information they're getting on masks or the safety of vaccines, they don't have a trusted source for healthcare. And so they are reaching out for other sources of information that are false or inaccurate. So what's the solution? Single payer healthcare. What does that mean? Healthcare dollars being distributed by one single entity, coordinated to eliminate gaps. It's the conceptual extension of Medicare to everybody. What is Medicare? Single payer system that's within our system. And it is the most efficient part of our system, with overheads of less than 3%, although that's not for the part of Medicare that's been taken over by private insurance that's administered through Advantage. What would we have? We would have universal comprehensive coverage. We would have no out-of-pocket payments. We would have a single insurance plan for everyone with global operating budgets. And the things that people worry about, would I still be able to see my doctor? The truth is now people are not able to stay with their doctor because if they change insurances, they may lose their doctor. The public setting overall health policies and priorities, medical decisions being made by patients and providers, not corporate executives. And a key part of this is the ban on for-profit healthcare providers. And why is that? We need that 31% back. We need to spend that 31% on actually providing care. And we need to change the structure of how we take care of people, right? Because we are profit driven, we have evolved into a diagnosis-based treatment plan. Physicians, hospitals, clinics are reimbursed based on diagnosis. And because of that, we don't treat people, we treat diagnoses, we treat diabetes, we don't treat Jane Doe with diabetes. We have lost our focus on preventive care because we are only paid when we are taking care of a given diagnosis. And there's this perception that, well, there's ways to do it if we just preserve private insurance companies and, get them to clean up their waste and put limits on them. And in a lot of ways, the Affordable Care Act was, that. And then the other possible plan that we're proposing when we're out talking to these groups is to create a national health insurance system. So all of that information, I think, is sufficient as a quick 20-minute introduction, and we could end my talk here. If people want more data, more specific cases, more specific information, I will spend the next 30 minutes delving into some specific data slides. So learning lessons about why the way things we have done have not necessarily helped, right? So simply giving more people existing private insurance hasn't solved the problem because we still have skyrocketing costs. We still have systems that are trying to avoid the sick. And ultimately, costs have continued to rise. A lot of people say, where will the money come from? I start back at the concept that the money is already in the system, but when people want more specifics, I find this slide very helpful, that we already have that money in Medicare, Medicaid, payroll taxes, income taxes, that all of those could go into a single payer health fund. And then that would go to individual providers, that would go to hospitals, that would go to eye care, dental care, et cetera. This is a slide that I'll never give up. It's kind of the concept that if everybody's on, that the truth is it's not that complicated. So one argument that I get a lot, and I get this conversation a lot from people who I consider our, members of our choir, other progressive movements, people in the reproductive and social justice movements, that this sounds great, but it's not politically feasible. So this is now actually inaccurate. 2/3 of the population want it, most physicians want it, and as I spoke before, the business community is realizing the need for it. This is a slide looking at increasing support for single payer and increasing support for single payer from physicians. And again, other politically infeasible movements. So the other conversation I hear is, no, but America is still better than the rest of the world. We are, the land of opportunity. If people would just pull themselves up by their bootstraps, et cetera, et cetera, et cetera. Medical bills are the most common reason for collection calls, 60%. This is people who forego other essentials, everything from groceries to clothing, to paying their utility bills so they can cover their healthcare costs. This is the data I spoke of earlier, that 2/3 of bankruptcy filers cite medical bills combined with illness-related work loss as the reason they went into bankruptcy. And this is the other concept that I mentioned, that the vast majority of people who are medically bankrupt had coverage at the time of illness onset and then lost their job or were unable to work because of their treatment. I have seen this countless times. Treating ovarian cancer is a combination of aggressive surgery followed by 6 months of chemotherapy, and working during those treatments can be extremely challenging, and many people lose their job during that process. The idea that our healthcare costs are being drained by immigrants. This is data from 2013 showing that the number that money put into the Medicare Trust Fund was being kept afloat by foreign-born citizens and non-citizens, subsidizing private insurance as well. I love this slide, right? Just because thinking about foreign medical grads as the people supporting our current healthcare system, as physicians, as clinical trial leaders, as percentages of academic physicians. And then I hear this a lot, and this question's actually near and dear to my heart, because certainly when I am standing in an operating room or rounding in the hospital or in my clinic, I feel like I am doing my best to provide the people I take care of, the people who come to me, with the best medical care in the world. But unfortunately, as a nation, we do not have the best medical care in the world. And we see this with lower life expectancy, increased infant mortality, increased maternal mortality, substantial healthcare disparities based on race and gender. Even Americans with above average incomes have worse access to healthcare. And then in the United States, we are more likely to skip care because of the cost than anyone else in the world. So then I get this whole discussion of like, well, Americans, they don't work out as much, they eat bad, they're fatter, blah, blah, blah. And of course, there's two discussions around this. One, if Americans are unhealthier, is it because our healthcare system is not as good as other people's, chicken and egg kind of thing? But the truth is, we aren't unhealthier than the rest of the world. We smoke less than people than countries that have better life expectancy than us. We are younger than much of the developed world. We spend fewer days in the hospital. We see less doctor's visits, although again, whether that's because we're healthier or because we have to pay more for it. We have fewer nurses than lots of countries. We don't provide long-term care. And this is great because we also tend to think of ourselves as the leaders of innovation and new discoveries and medical research. And unfortunately, it's not true. If we even look at something as simple as the number of articles per capita, we pay more out of pocket than much of the world. And then when it comes to specialty care, right? US patients whose kidneys fail are less likely to get transplants. And this is kind of an interesting problem because it's driven by something quite specific. And that is that dialysis centers are often owned by kidney specialists who therefore have an incentive to have patients go on dialysis over getting transplants. There's a number of great sources for that if you have questions, we can get to. So our problem, for-profit motives and the bureaucracy it entails. This is the investor-owned dialysis clinics discouraging transplants, right? In the VA, less dialysis, better survival because VA nephrologists are not incentivized to push patients towards dialysis. US public spending per capita exceeds the total spending of other countries. Then you add the private spending, and of course, we outpace them dramatically. Insurance overhead per capita, right? Substantially higher, 10 times almost higher than some other countries. And then you think about those companies that are somehow completely recession-proof. Drug companies, completely recession-proof. Looking at their profits from 1995 to 2019, really not even being touched by the recession of 2008. And this is, another little piece of falsehood, right? That it's only private insurers are only getting private money. Absolutely not. 52% of their revenues come from Medicaid and Medicare that are administered, in quote, through private insurance, the, in quote, advantage plans. The argument that it's because drug companies are working so hard and doing such vital research, that's why they're so expensive. 13% of drug companies' cost structure being spent on research and development. A high percentage of true innovations happen within the National Institutes of Health system or academic research institutions. This is sort of a terrifying slide, right? Really, if you look at the number of physicians in the United States, that little yellow bar at the bottom versus administrative growth, and the number of managers and bill figure outers, et cetera, with substantial growth since 1970 as more and more healthcare has been taken over by for-profit motives. Duke Medical Center, 2018, 957 beds, 1,600 billing clerks. Profits in 2019, pharmaceuticals, $83 billion. Insurers, $23 billion. Equipment and supply, I mean, these numbers are outrageous, right? Where is the money? What can we afford? This is where the money is. This is where we can cover dental. This is where we can cover optical for everybody. This is where we can treat mental health like we treat the rest of the body. Healthcare CEOs pay. Again, outrageous numbers. And, the challenge of that is, that not one single one of these people ever touched a patient. Health system profits in the nonprofit system, right? Kaiser, Mayo, Baylor, university systems, extremely profitable, still taking advantage of nonprofit status. Hospice, when hospices went for profit, that was after I completed my training. And as a gynecologic oncologist, a substantial part of my training was about palliative care and helping patients at the end of life, helping them achieve their quality of life goals. And when hospice went for profit, I, as somebody's private, personal oncologist, was cut out of the system. I couldn't participate once they went to hospice because, obviously hospices didn't want to pay me for my services. Just, one of the many examples of the chipping away at quality American healthcare when you add this for-profit motive. Kind of insane, right? You would think that if anybody would not be avoiding unprofitable patients, it would be hospice. And unfortunately, it's not true. This is like an important part and a difficult thing to talk about. But the fact that doctors spend twice as much time on electronic health records and desk work as with patients is important. And you might say, well, gosh, I guess we're just more, literate or productive or better note takers. And it's completely and utterly false. Doctors spend time in electronic health records and doing desk work in order to fulfill the high bureaucratic needs of our extremely complicated reimbursement system, adding in diagnoses, charting our time, adding in all the pieces that it takes to maximize billing and reimbursement for the part of whatever organization it is that we work for now. US electronic health record notes being 4 times longer than other countries. Again, is it because we're just really wordy? No, it's because our system requires us of it and we waste time doing it. Finally, thinking about what would be better for American businesses and American innovation, right? Health costs growing share of employee benefits, that little yellow bar there. More and more and more, the things that unions fight for are excellent insurance coverage, not things about current care, not child care needs, not better time off, et cetera, not better working conditions, no, just basic need for healthcare. And think about yourself as a business and part of why this is so hard to implement, right? I'm a small business owner and I am obligated to provide healthcare, and that's something that as a small business, I can't necessarily sustain. All right, so we are at the 40-minute mark, I think. And I have additional data slides. And again, we could make this into a slightly separate talk or offer it to people separately. but other data that I think is valuable when we talk to different groups, data slides that you might want to add depending on who you're talking to. This is just a slide that demonstrates a number that I talked about. We'd seen some decrease in the uninsured with the Affordable Care Act, but have lost many of those benefits. This is that other number that I talked about, the 39,000 deaths due to uninsurance, excess death in different states in the United States. Health deductibles that cut care, people unable to pay for their CAT scan, pay for their physical therapy because that's a higher cost that they can't afford. Data on people who delay care because they are uninsured or underinsured. Looking at the issue of not just decreased life expectancy, but health disparities. Increasing deductibles for people who have coverage. Insured cancer survivors with high out-of-pocket costs. Imagine somebody who's 70 in otherwise good health gets diagnosed with cancer, having $8,000 of out-of-pocket costs when they are no longer working on a fixed income. Right, and then criminalizing the uninsured. Perfect. So I think that's a good place to stop. I think the rest of the data slides I have are probably accessible and don't need to be part of this talk. So it's hard to not offer up myself for questions, but that's the limitations of a recorded system.